Pediatric sedation carries an immediate physical threat: the sudden, unpredictable loss of protective airway reflexes and baseline respiratory drive, the behavioral control and anxiolysis needed for the procedure, while maintaining the patient's independent ability to breathe. Pharmacological sedation behaves as a fluid continuum. A patient intended for minimal anxiolysis can slip into deep sedation or full general anesthesia in seconds, losing the ability to protect their own airway. This 5-step safety algorithm serves as the primary defense against cardiorespiratory collapse, providing a rigid architecture for every outpatient pediatric procedure. This text defines the standard of care. Safety depends on a continuous, structured culture of vigilance that extends beyond the pharmacology itself. Administering these sedatives is the execution of a continuous system designed to anticipate and immediately reverse physiological failure. Defense begins with triage. A child's systemic health determines whether the procedure happens in a clinic or requires the resources of a hospital operating room. These guidelines approve only ASA Class 1, normal, healthy children, and ASA Class 2, those with well-controlled mild systemic disease, for non-anesthesiologist procedural sedation. Children with severe systemic disease, or fragile ASA2 patients, those with uncontrolled conditions on the day of the procedure, mandate referral to an anesthesiologist. Even a systemically healthy child can be compromised by a structurally dangerous airway. Structural hazards like macroglossia, mandibular hypoplasia, or kissing tonsils create physical bottlenecks. Under sedation, surrounding tissues relax, and these bottlenecks can become complete obstructions. Clinicians use the Mallampati score to assess this risk. By grading the visibility of the uvula and soft palate, they calculate the difficulty of a potential emergency intubation. Specific comorbidities, such as severe obstructive sleep apnea or extreme obesity, alter the patient's underlying neurochemistry. Repeated nighttime desaturations lead to altered mu receptor sensitivity. These patients reach deep analgesia at opioid levels 1/3 to 1/2 the standard dose, making standard dosages a high risk for respiratory arrest. Preoperative triage provides a predictive map of where a patient's physiology is most likely to fail under pharmacological stress. Pharmacological sedation also disables protective reflexes, creating the risk of pulmonary aspiration, the regurgitation and inhalation of gastric contents into the lungs. Clinicians mitigate aspiration risk through strict fasting: 2 hours for clear liquids, 4 for breast milk, and 6 for solids. But emergency departments lack this luxury. Withholding analgesia from a child with a displaced fracture is difficult to justify solely based on a recent snack. To manage this, practitioners select dissociative agents like ketamine or use regional blocks, titrating to the lightest effective sedation to preserve the patient's gag reflex. While strict fasting neutralizes elective aspiration risk, emergency sedation requires a dynamic balance between the certainty of pain and the probability of airway compromise. The risk of unintended general anesthesia requires that every single procedure room be engineered for immediate physiological rescue. This absolute necessity drives the preparation phase of the protocol. Before induction, the team executes the SOAP-ME checklist for readiness. The first 3 establish airway control: suction, an oxygen source, and airway devices. The final 3 secure metabolic support: pharmacy, monitors, and special equipment like a defibrillator. Within the pharmacy requirement, pharmacological reversal agents like naloxone and flumazenil must be drawn and immediately accessible. Safe sedation relies on the assumption that a code-level event will occur. The room's architecture must be capable of supporting a full resuscitation within seconds. Active administration begins a phase where physiological variables fluctuate by the minute. Baseline monitoring requirements for moderate sedation change significantly when moving to deep sedation. Deep sedation requires an independent observer dedicated solely to monitoring, and it makes capnography, the continuous tracking of expired carbon dioxide, mandatory. Targeted drug selection matches the medication to the procedure: hypnotics for motionless imaging and analgesics for painful interventions. Mixing agents triggers a synergistic multiplier. Combining an opioid and a benzodiazepine creates an exponential spike in respiratory depression. To stay beneath the apnea threshold, drugs must be sequentially titrated, waiting for the peak effect of one dose before introducing another. If the airway becomes obstructed, the practitioner must possess the mechanical skills to immediately apply continuous positive airway pressure or perform bag valve mask ventilation. Intraoperative monitoring provides a real-time early warning system to detect a drop in respiratory drive before it causes permanent injury. After the procedure ends and the stimulus is removed, the patient enters one of the most vulnerable phases of the continuum. Circulating metabolites can cause resedation and delayed airway obstruction, even after the child appears to be waking. To prevent discharge before the drugs have cleared, patients must meet 4 rigid medical benchmarks. The patient must maintain oxygen saturation over 90% on room air, demonstrate stable hemodynamics, and regain autonomous airway reflexes. They must also pass a 20-minute quiet wakefulness test to ensure they do not slip back into apnea when left undisturbed. Final discharge includes strict instructions for guardians. Infants in car safety seats face a high risk of positional airway obstruction, requiring active observation for the duration of the ride home. Success is only secured once the patient has navigated the physiological gauntlet and returned safely to their pre-sedation baseline.